Hi, everybody. Welcome to today's Student-Led Journal Club seminar. My name is Anne-Marie Hayes. I'm a research associate for the Joplin campus of KCU. Today, I will be introducing student Dr. Grant Bednar, who's going to be talking to us about clinical applications of artificial intelligence and their use in gastroenterology. Student Dr. Grant Bednar is a second-year DO student at Kansas City University. He is originally from Grand Island, Nebraska, and a graduate of Nebraska Wesleyan University. Prior to matriculating at KCU, he worked as an EMT at Children's Hospital of Omaha and a CNA at University of Nebraska Medical Center. Student Dr. Bednar is active in research at the University of Kansas Medical Center in the Radiation Oncology Department and has a wide array of medical research interests. In his free time, he enjoys watching Nebraska Cornhuskers football, skiing, and running. So with that, the floor is yours, student Dr. Bednar.
Awesome. Thank you so much, Anne-Marie. Kind of like Anne-Marie said, I'm a second-year student here on the Kansas City campus, and I'm really excited to talk about just AI and how it can be useful, especially in the realm of endoscopies and upper endoscopies, and just the future of AI and how it's going to just revolutionize medicine as we know it. So just a little bit of background, though. Just to kind of give a brief overview of kind of what GI specialists do. A lot of what they do is diagnose and treat cancers of the GI tract. And so just to give you a little bit of background of the statistics of GI cancers worldwide, as we know, colorectal cancer is very common, and it takes up a large amount of those cancers, unfortunately, up to 26% of the global cancer incidence worldwide. And that includes skin cancers, pancreatic cancers, everything under the sun of the realm of cancers. And unfortunately, it takes up 1/3 of cancer-related deaths. I believe the CDC estimates 4.8 million new cases every year, as well as 3.4 million deaths worldwide, and that was back in 2018. NIH says this statistic is not going away anytime soon, and the highest incidence is in the colorectal area, right around 1.8 million cases annually. And that takes up around 10 to 9% per year, depending on what research you're looking at. Specifically diving into colorectal cancers in the United States, colorectal cancer is the third leading cause of cancer-related deaths in men and women. Unfortunately, 1 in 23 men in the United States will develop colorectal cancer, and 1 in 25 women will be diagnosed with colorectal cancer. So very high statistic. I'm sure a lot of us have a family member or someone that we love and cherish dearly that has been diagnosed with this terrible disease. The American Cancer Society estimates back in 2020, there was well over 100,000 new cases of colon cancer and close to 45,000 new cases of rectal cancer. So this is just in the United States. It's very, very common. The wonderful thing is that it's very preventable with routine colonoscopies. Right now, the recommendation is routine colonoscopy after the age of 45, and those have been proven very effective in preventing colorectal cancer. And that statistic from the New England Journal Med predicts up to 90% of colorectal cancers are preventable through the removal of precancerous polyps, such as during a colonoscopy. So that's great news. So you might ask yourself, why is this statistic still high for deaths as well as colorectal cancer instances, even though it is preventable? And the large answer is due to physicians just not being perfect. As every human being, we have our shortfalls and shortcomings, and unfortunately, in a typical career of a GI specialist, they will miss up to 80 to 120 colorectal cancer diagnoses. And that might seem like not very many misses compared to what they might do on a lifetime of the typical GI specialist does around 20,000 colonoscopies in their career. So it seems like a very small number, but obviously 80 to 120, we would like that all the way down to 0. And this is largely due to missed polyps or colorectal cancer diagnosis, as well as complete polypectomy. So when they are removing a precancerous adenoma in the GI tract, the GI specialist or gastroenterologist might miss taking out that full cancer. Also, inaccurate pathology might be a reason as well, and de novo progression such as Lynch syndrome or a different genetic abnormality that might be out of the control of the GI specialist. Dr. Carnes at UCLA predicts that approximately 85% of the time it's due to those top two. So either they're missing a polyp or a diagnosis of colorectal cancer, as well as just not being able to take out the full sample when they are removing precancerous polyps. So again, how do we fix this? And one answer is artificial intelligence. For those of you who aren't familiar, AI is basically a robot that can mimic human intelligence, and it can perform tasks that we can do every day as humans, but it just makes it more efficient and better. And we can definitely use this in the realm of medicine. Forbes predicted this year that it is going to be the next industrial revolution. A lot of us have seen and witnessed it being already impacted in a lot of sectors worldwide. And it's considered the fastest growing technology in the world right now. Like I said, it's going to impact every sector of medicine, whether we see it or not right now. The number one is going to be drug development and disease diagnostics. AI has a huge potential in these things, and being able to assist doctors in preventing medicine, as well as treating different diseases, as well as possibly curing them. And it allows for personalized treatment for that patient and managing their medical data as well. So the spectrum is very wide, and I'm really excited to talk about this topic because AI is really a passionate topic of mine, and I love to research it in my spare time. So I'm really excited to kind of talk about that and how it relates to GI specialty in general. It can also impact imaging. So we've already seen this with different radiologists, their imaging, whether it's CT, MRI, X-ray, routine. AI can see images and be able to develop a possible diagnosis, and the doctor just approves of that. And we've had a few speakers last year on the Kansas City campus that are radiologists talking about that type of research, and that only inspired me to give this talk today. So a little bit of background. I know we have a couple first years on this Zoom call, so I'm just going to give a brief overview of what gastroenterologists do. So as I mentioned earlier, they do colonoscopy. So that's just an endoscope that goes up the rectum and is able to view the sigmoid colon all the way up to the ileocecal valve. So it flags any precancerous lesions, and the doctor is able to clip those lesions as well. That's used for colorectal cancer screening. Also, upper endoscopies is a scope that goes through the mouth, and it's able to go down all the way to the esophagus, the stomach, as well as the duodenum. So that's why it's called the esophageal gastroduodenal endoscopy as well, EGD. That largely has to do with Barrett's esophagus. So doctors use that. It's a disease of the upper stomach, lower esophagus, that gives you a higher risk of developing adenomas, especially in the United States when it comes to undiagnosed GERD and things like that. So that's what upper endoscopies are used for. Also, video capsule enteroscopy is a small pill that is a camera, and it's able to help the doctor look at the small intestine. So a lot of doctors use this to look at cancers of the small intestine, or if they have undiagnosed celiac disease or things like that. So it's just another tool in the toolbox that can help diagnose things like inflammatory bowel disease. Also, GI specialists are really involved with the pathology as well as the imaging. So how do we get to AI and GI? So I developed this kind of little roadmap to say, and the first step is to collect data. So data is the key to developing AI system. And I'm no AI specialist, but I know from talking to a lot of doctors as well as listening to a lot of podcasts about AI, the AI is only as good as how much data it gets and the quality of the data. So a lot of researchers have to collect that data, label the data, as well as train the AI system and develop software that it's able to utilize in everyday settings. And a large part of what GI does is obviously video and imaging validation. So a lot of the GI AI systems are able to look at this video and capture images as well as do other things, and a doctor has to sign off on that and say, yes, this is an adenoma, or this is a polyp, or things of that nature. So also develop the interface as well as clinical validation. Kind of like I said earlier with the video and imaging validation, there's a lot of steps, and the AI can obviously be trained and gets better and better as we go. But it has to be tweaked here and there because it might detect some false information. So a lot of it has to do with keep retraining and trimming things that are being incorrect and taking those things out, as well as being cleared by the FDA. So we're seeing a lot of these tools I'm talking about today that have either been cleared by the FDA or in the process of getting cleared by the FDA. And that's going to be a huge hurdle. As we know, with a lot of drug development, this is one of the lengthiest times of the process, and it's no different for AI-assisted GI specialists. And also implementing live. So that just means taking it to the masses and using it in hospitals and clinical settings. And as I mentioned earlier, the AI is just data plus the algorithm. So it's only going to be as good as what you're feeding it, meaning the data that it's given, as well as the interface and algorithm that it's been given as well. So where are we at today with AI in GI? Right now, artificial intelligence can correctly identify, characterize, and phenotype polyps with rising accuracy. It can measure the polyps, differentiate polyp types, even prior to it being biopsied, which is incredible. And I'll demonstrate that as we go along here. It can also identify landmarks such as the cecum, gastroduodenum, et cetera, and they can timestamp those. So this is a huge burden for a lot of GI docs because earlier on, they had to look at the time and constantly look at the time of when they're passing the mouth or these specific landmarks, but the AI automatically captures that and is able to timestamp that without even them thinking twice about it. It also challenges doctors to improve bowel prep scores. As we know with these procedures, the colon and the esophagus and the stomach has to be cleared out. There's a lot of prep that goes into that. And a lot of doctors use these scoring tests to rank those types of bowel prep. So the AI can sense how clean the rectum is even without the doctor even being able to decipher that for them. It can also recognize tools that the doctor is using, and I'll show that as we go a little bit. And it can auto capture images, and it even documents it all for the doctor. So at the end of the procedure, in the future, the AI will be able to automatically integrate it into the EMR system and chart, and the doctor just tweaks a little bit here and there and adds a personal note, and it's automatically done for them. And it timestamps everything of the procedure as well as the precancerous lesion, even before it's sent off to biopsy. So this is going to be a huge development, and I'm only excited to see where we go from here. So here's kind of a little snippet of what the doctor might see with a colonoscopy in general. So on the left-hand side, you can see that it can give a detection score. So this is detecting an adenoma, and it gives a predictive value of what it thinks that polyp might be. So it's detecting a 55% chance that that's an adenoma. Obviously, they would have to biopsy that and snip it as they continue that screening. Also notice that it can give a proper size. And so that's going to be huge for the doctor. So as the doctor is using the endoscope, they're controlling everything, but the AI is just picking out these boxes that they might miss and highlighting the areas that they might miss during a routine screening. So in specific, how AI is assisting colorectal cancers screening. As I've mentioned before, it can differentiate polyps with rising accuracy. Right now, there's quite a few studies being done, especially in the US as well as other countries in Asia. And what they've noticed with AI-guided colonoscopies is that it can accurately differentiate hyperplastic from adenomatous polyps with a predictive value of 90%, which is significant. And this is great for cancer diagnoses as well as other things, as well as being able to tell them how often they need these screenings done. But the difficulty with this AI system is that it's difficult for them to treat and being able to come up with the diagnosis of advanced adenomas and metastatic adenomas. And I just think this is largely due to the fact that it's just not being routinely used. So as I mentioned earlier, the AI is only as smart as how often it's used and how much it's tweaked. So I think as we use it more and more in practice, this will only improve, as well as technology being improved as well. Also, landmark recognition is huge, and the doctors have been applauding this for years already. It can properly identify the cecum with 99% accuracy, as well as start and stop times 100% accuracy. Other variables, such as other different landmarks, are pretty variable, with 40 to 60%, depending on what area you're talking about, whether it's the esophageal, stomach, just different areas. The AI system is constantly being tweaked, like I've mentioned, and it's only going to get better. It can accurately predict the size as the morphology, 90% accuracy with that. And this bottom right photo kind of demonstrates a 3D image of the colon. So as the doctor is doing the probe, it can make a 3D image of the colon, which is significant, where it can accurately map and tell the patient where they might predict these cancers might be and where it might be spreading to. So it gives the patient a better idea of what's in their body, and it gives the doctor a better idea for education purposes as well. So here's a video of Dr. Carnes. I mentioned him earlier. He's a pioneer with this technology, and he's out of UCLA. And I just happened to stumble across this YouTube video, and he demonstrates kind of his technology and how it's being able to be implemented in his practice, in specific how it can be used for his cancer diagnosis for colonoscopies.
Trying to perfect the interface. What you can see in the upper left is the Boston Bowel Prep score. It's going to be showing that live during this video, whether a tool is being used, and if so, what tool, and whether it's looking at the cecum or not, and whether it's inserted or not. And over on the right upper part of the screen, the probability that there's a polyp on the screen. And if there is a polyp with high certainty, you'll see a box on the screen showing where the polyp is, and it'll attempt to predict its pathology. So you can see cecum. It predicts that polyp to be serrated. It also predicts this one to be serrated. This one, it can't really make up its mind, but narrows in on adenoma. It's recognizing the forceps. This is showing that we can run this live during an actual procedure. And we use YOLO, which means you only look once. It's an algorithm that helps you draw perfect boxes around the polyp. Or it helps the AI do that. This is a side-by-side comparison. The screen on the left is running through the AI box, the video through the AI box to the screen. The screen on the right is the actual live video. You can see there's really no detectable lag. And it's detecting an adenoma there and a little hyperplastic polyp there.
So as you can see with this video, he's able to utilize that AI and might find blind spots that the doctor might miss. And especially when it comes to this video right here, this little screenshot, it's kind of difficult sometimes for the endoscopy to be able to even view what the doctors even be able to see, whether it's glare or the lighting. But the AI is becoming even smarter and smarter, and it is able to draw these boxes around certain areas that might be of concern. So it's pretty incredible technology. So moving on to upper endoscopies, this was a little bit tougher to find statistics on, just because upper endoscopies are utilized in the United States, but the cancer diagnoses are more common for the colorectum area. So it's more focused on colonoscopies and how it relates to AI in the United States. But there's a lot of research out of China that utilizes this technology. So right now, China, there's a couple researches that's been done, and they've said that there's an accuracy of 90.4% of real EGD videos. Blind spots, this detects just areas, like I mentioned before, areas that the doctor might not be able to view. So the blind spot rate was 5.86% with AI guided technology compared to just human only with 22%. So significant drop with this AI guided technology. Obviously, there's just over 300 participants in this study, so it's a little bit more difficult to come up with real life data to this. But some of the pros that they mentioned, which I found interesting, was it provided the doctor with real-time feedback. Kind of looking back at that video I showed earlier, the doctor can utilize and control where the endoscopy is going, but it just draws boxes around areas that might be of concern. Also, obviously reduces blind spots by a significant amount. Some of the cons that the doctors mentioned in the study is that it was kind of distracting. So the boxes would want to go over areas that it thought were concerning, but the doctor didn't think it was concerning. So this ended up being a poor patient experience because the upper endoscopy ended up taking a lot longer procedure because of this problem, because it spent too much time on those targeted areas. But as the technology improves, I think this would be tweaked as we go further. So in upper endoscopy with AI guided technology, this is kind of a snippet of what the doctor might see on the computer screen. So on the top left-hand corner here, the probe is going through the stomach, and it's able to actively know where the part of the stomach is that it's viewing, as well as make a 3D image. So on the bottom left here, it's kind of coming up with blue areas that might be of concern that the doctor might use, as well as make a 3D map of what the surface might look like to the doctor, and for education purposes for the patient as well. And then for those of you who aren't familiar, Barrett's esophagitis, I kind of talked about earlier. It's a disease of the upper GI tract, and Dr. Carnes out of UCLA kind of talks about the research with this too.
Of what Jason's been working on with Barrett's. For those of you who are Barrett's experts, you'll notice on the right side that there's a little bit more disorganization in the pattern. And under NBI imaging, you can see that the AI recognizes that disorganization, and this happens to be an area of dysplasia. As you keep watching the video, you'll see that they pan around to more normal Barrett's, and the AI is silent. So the advantage here would be, we take random biopsies, then you wait, then you find out there's high-grade dysplasia. You have no idea where that biopsy came from. So you go back in and then you do some ablation or something. If you could, at the moment you're doing this procedure, make that diagnosis, you could do your intervention right then and there.
And I think Dr. Carnes has a great point there for those of you who might not have heard. They might take random samples of the biopsies as they go down along the GI tract, and they might not know specifically where they're taking those from. So this AI imaging is great because it's able to detect a certain dysplasia area of growth, and they might be able to snip that area and know exactly where it's at in the GI tract, which is huge, going to be huge for doctors.
Of what Jason.
So moving on to my last topic is video capsule enteroscopy. I had mentioned it earlier, but it's this little pill-sized camera that you are able to swallow. It's routinely used by doctors across the world right now, but it's mainly used for purposes to look at the small intestine. And so AI can help with this as well. Some research shows that it's significantly reducing reading time. So from the literature, doctors are kind of hesitant about using video capsule enteroscopy because it takes so much time reading these cameras, because it takes thousands of images as well as videos of the small intestine, and doctors have to kind of sort through and look at all these areas of concern. And it's predicted that the doctor had over 50 minutes to view, and that's kind of a big hindrance for doctors, especially when it comes to patient care, being able to sit there and watch, and they don't want to miss any diagnosis. But the AI assisted wireless capsule, the video capsular enteroscopy, is able to just give a shortcut and give the doctor areas of concern, and that reduces it to around over 5 minutes. So that's a huge significant, and that's a reduction rate of, well, close to 90%. So this would be great. It's also improving accuracy for these. And as it becomes more and more available, it's going to be more clinically acceptable as well and cost effective. One of the wonderful things is that this technology is already used. And so with adding AI to this, it will influence patients immediately. So where do we go from here? Obviously, lots more research and development still needs to be done, as well as with any research. But the accuracy of the AI in real time, just giving it different scenarios, is key. I've mentioned it over and over during this talk, is AI is only as good as how much data it's given. So if we're able to give it more and more data, it's going to be even more and more better. And as we tweak it more and more, it's going to improve patient outcomes. Also, I've noticed a lot of the literature talking about hardware specific versus universal availability of this AI. And what this means is that a lot of biomedical technologies are developing software as well as enteroscopy techniques that are proprietary to their software. And there's a lot of discussion whether to make it universally available, meaning that whatever hospital, whatever upper endoscopy company that they might use, that they might utilize a different company's software with their equipment, just to reduce the cost availability with that. Because cost of hardware can be significant with this technology because it is new. A lot of hospital chains will have to add tech support as well as EMR integration. Also, with anything in medicine, reimbursement is huge, and insurance has to be able to approve and validate that this works. And the public has to be confident in this technology as well as the doctors. So you have to have willingness from both sides, both parties, and just a overall reliance on this technology. And like I'd mentioned earlier, just more randomized control trials will be huge with this, as well as being cleared by the FDA. So why does this matter? Obviously, with AI-driven technology, it's going to reduce cancer mortality. So compared with no screening, the reduction in colorectal cancer mortality with screening was 48%. So obviously, this is already used in today's world. A lot of people use colonoscopies over the age of 45. So this is able to reduce the colorectal cancer incidence as well as mortality. But with AI-guided colonoscopies, it even is reduced even higher to 5.2 or 52.3%. So it's gaining 3.6% gain. And this is just with the, I think this study was out of 2020. So it's only going to get better and better as the years go on. Also, AI-assisted colonoscopy saves money and lives. At the population level, in the United States, it is predicted to prevent over 5,000 colorectal cancer cases and over 2,000 deaths. So this is significant. And it's going to save the U.S. close to $300 million in hospital stays, as well as drug costs associated with cancer diagnosis. So overall, better cancer screening obviously equals saving lives, making better patient outcomes, as well as a higher ADR rate. So for those of you who might not be familiar with ADR, it means adenoma detection rate. So a lot of insurance companies reimburse doctors, Medicare and Medicaid reimburse doctors based on their adenoma detection rate, meaning how many adenomas they're missing, as well as how many they're properly taking out. So with this AI-driven technology, it's only going to increase their adenoma detection rate, giving hospitals even greater success with patient outcomes. And it gives more time with patients. So as you saw with the video CAPSULEs, the doctor's reading time is significantly reduced. So this gives more time to educate the patient, as well as give them more time to talk with them, and giving them more patient load to do more procedures, as well as just giving them more flexibility. So that's great outcomes for doctors as well. And obviously higher accuracy and better diagnosis. One misconception that a lot of people have is, will doctors lose their job to robots? And the simple answer is absolutely not. As we've seen with any technology that we have today, no technology is ever perfect. It will constantly require physician guidance and approval, and constant tweaking as the data comes in. The AI machine, I've mentioned this over and over, but I really want to hammer it home, is that the AI machines require the humans to interact with it. And it's just going to be another toolbox in the doctor's, it's going to be another tool in the doctor's toolbox to use. And it's only going to just help the doctor be able to find blind spots that they might miss during routine procedures. So I'm just going to end this on this meme in honor of October. For people who can't see, it says, and because it's October, you have the choice of a regular colonoscopy or pumpkin spice. So for those of you who like pumpkin spice, there you go. And here's my references, and I'll leave the floor to any questions.
Awesome. Thank you so much, student Dr. Bednar. Amazing presentation. As he mentioned, if you would like, raise your hand in Zoom, or if you can't chat, you feel free to type it in the chat and I'll read it out. It looks like Dr. Johnston, you have a question.
I do. Grant, I've got about 3 of them. And first of all, before I ask my questions, I want to compliment you on the quality of your presentation. It was excellent.
Thank you.
Excellent command of those slides. Your tempo was really good. The pictures, the videos were crystal clear. So, and the yield of the content of the slides was simple to understand. So I appreciate that.
Thank you.
A couple of things going back. What was the name of the syndrome that you had implied from a de novo progression of the disease? You mentioned the name of the syndrome. What is that syndrome?
Lynch syndrome.
How do you spell? Can you say it again?
Yep, Lynch syndrome. It's
Lynch.
L-Y-N-C-H.
Yeah. Okay. I couldn't understand what you said. Lynch.
Oh, I'm sorry.
Okay.
Yep.
Polyps and Lynch. Okay.
Yep.
Yeah. All right. The other one is, can you rationalize or explain with a little clarity how it picks up? There's always a challenge to every colonic prep,
Right.
and who's cleaned out and who's not, et cetera. What does it do? How do you use that to challenge how clean the bowel is prior to endoscopy? What goes into that formula? How many bowel movements you have, or how do you decide that?
Yeah, so Dr. Carnes was really passionate about that. I just didn't have enough time to show that piece of it. But essentially, the AI can, as you're going through the colorectum area, there's some leftover, obviously, residue along the walls of the colon, and the AI is able to pick that up and give a score. So I think they use the Boston Bowel Prep score, is what it's commonly known as for GI docs. And the AI is automatically going to give a score with how much residue is along the side, and it can automatically detect that. I think it's due to just discoloration, as well as being able to pick up the size of it. But I think that's answering your question.
Okay, well, the endoscopist is going to see that.
Right.
So,
But I think the doctors have to give a score with how well the rectum is cleaned out, and this AI is just going to help with that scoring.
okay, very good. The other thing I wanted to ask is the ability of the procedure, the technology to pick up lesions before the doc can see them. That's how I say this in respect to the procedure, but how often, or what's the sensitivity of a false positive versus no, that's nothing? Is it programmed to overread it? Too much sensitivity to it, or not?
I'm not sure if there's any data on that.
Okay.
I know for colorectal cancer, they just snip any polyp that they can find.
Yeah.
Because, adenomas can develop into cancers when it comes to, especially the colon. So I don't think they're necessarily looking at whether it is cancerous or not. That would be up to the pathology to show, but I think this research was mainly focused on being able to detect areas that the doctor might not see. So I think there would be an increase in the false positivity rate just because of that.
Yeah.
But I think they just take out anything that might be of concern.
So the doctor still has discretion and can use that discretion whether or not that there's a spot with a box around it to biopsy or not.
Right. So the doctor's still in control of the scope. It's just the AI machine is able to give them areas of concern that they might miss, as it is now.
My last question to you was on the video camera, and the sensitivity of the video camera in picking up occult bleeding versus or with AVMs or things like that. Did you see any data supporting, hey, this is where we need to go with this video camera to help us diagnose this GI bleed because we can't see it? Occult bleeding, any data there?
I didn't see much on that, just because I think this is relatively new technology that they're focusing more on the adenoma detection rates and that sort of thing. But yeah, that would be really interesting to look at, because obviously one of the symptoms of colorectal cancer is bleeding, and that's a large portion of what the GI docs see is bleeding. So I think that would be really interesting. I just didn't really focus too much.
Again, you've really done your homework on this topic, and I applaud you for your quality of your presentation. Nice job.
Yeah, thank you so much.
Awesome. Any other questions, comments? I do have one question, if nobody else does. I wasn't going to jump in front of somebody, but at the beginning of the presentation, you mentioned a lot of the stuff you kind of like to dig into personally, and you mentioned podcasts, and I was just wondering what podcasts you listen to or what research-based podcasts you recommend.
Yeah, so I haven't found a good one specifically on AI, but I'm kind of a tech junkie. I know there's a ton out there. I can't name them by name, but one of them that I commonly listen to is called The Motley Fool. and they have a bunch of different podcasts on this AI technology and kind of stocks. It's more stock oriented, so it kind of gives you ideas of the rising biotechnology companies that are growing and finding different research in this field.
Awesome. Thank you. I
Yeah.
do enjoy a good podcast, so I'll give that a listen.
Yeah, you bet.
Dr. Wolf, I think you have your hand raised.
So I actually had a couple of questions for you. So my understanding was that years ago, among the main problems with colonoscopy was that they stopped too soon, that they didn't advance far enough. Is that still a problem, or is that?
That's a good question. I haven't seen that in the literature I was specifically looking at with the AI driven technology, but that would be something that I'd like to look into.
Well, and related to that, you mentioned the idea of reimbursement.
Mm-hmm.
And with things costing money, among the challenges always is that if you expect somebody to pay for it, it's got to be worth it to them. So to what extent do you think you're actually going to save clinician time versus having them spending time with the AI and with, the patient or whatever, is that there really isn't a time benefit, and they're trying to charge a lot more money for it, and the insurance companies go,
So I think obviously the AI technology is probably a little bit more expensive than it should be right now, but as this becomes more and more available, we've seen this with a lot of different technologies, it's going to be more widely adaptable, and patents will run out, and this will be more commonly used. And I think this will just be a streamlined basic thing that a lot of doctors will have. But in terms of reimbursement, there just isn't a lot of confidence yet in this technology, just due to it being so new, and the doctors and researchers having to constantly tweak different aspects of what they're doing. So I think there just needs to be flat out more data for these AIs to use, and that with more data comes more reliability as well as better studies. And with that would come along with more insurance approval and reimbursement with that. So I think we're just in the early stages, but as this keeps growing and gets better and better, it will happen down the line.
I was at Creighton and they got a PET scanner early in the PET scanner years, and they lost their focus on the PET scanner because there was no reimbursement and it wasn't used enough. My final question actually related to another point that you made, and that was that you were talking about drug development and things like that. And you're not old enough to know that, back when the human genome was sequenced, by now we were all going to be running around with our DNA on a flash drive, and we would plug it into the computer. And then the physician would be largely like the mechanic that doesn't know what's wrong with the car until the computer tells them what's wrong with the car. And I don't think we're anywhere close to that. So I was curious where your confidence was coming that we were going to get there in the foreseeable future.
I would definitely see it coming in the foreseeable future. It's already as this is developing further and further with the technology, you already see it out of China. They're using a lot of the AI-driven technology to develop drugs, and as patents become obviously key to a lot of these for drug makers, I think the money involved and the just the power involved with that will drive the technology even further. Right now, the technology isn't there, so you probably aren't seeing it much. But as more money becomes involved, and as countries start to fight over kind of their realm of drug development and being able to control these patents, I think there's going to be more and more battle and more competition to get to that race. We're just in the early stages of that right now. But yeah, I'm really fascinated with the genomic code and personalized treatment. So I think by the time, and I talked to Dr. Staudinger yesterday and Anne-Marie, I'm very excited as a future physician to be able to have this tool in my toolbox eventually. I know you always talk about the future and, oh yeah, that seems like a good idea and very futuristic, but I really do believe, and I'm really passionate that this will be a utilized technology, and we're just on the cutting cusp of it. And you talk to any younger person right now, the technology is growing so fast and so rapidly that it's hard to even comprehend and put their minds around how different medicine will be in 20 years down the line. And I'm just really passionate about this topic, and I'm thankful to be able to kind of give a glimpse of what GI might be in the future. So sorry, I hope I had answered your question there. I kind of got on a soapbox.
No, that was fine. You know, it's just that we've seemed like we've been on the cusp for a long time, and we've developed amazing technology, but I'm not sure that we have the data to fully apply it.
And I would agree with that too. I'm not too much up to date on pharmacologics as you, and I'm sure that is frustrating, but hopefully we can get to a point where it's more commonly utilized, especially in pharmaceuticals.
Awesome. Great discussions, everyone. I just wanted to say really quick, a really good comment was thrown in the chat in response to the podcast question. Someone said, Behind the Knife is a good podcast for general surgery topics. It often highlights new technologies. So I just want to throw that in case anyone's just listening to the audio. And then they also said AI is also being developed to help ensure safe gallbladder dissection. So pretty cool.
Very cool.
And I have a comment for you, and I don't know that, you know, the clinician's index of suspicion, I think will trump any technology. And I say that based upon over-reliance of the technology.
Mm-hmm.
I think we could use the AI to enhance our clinical suspicion. But I don't know that it's going to replace the guy driving the scope.
Absolutely.
Index of suspicion still remains the art of medicine.
Yep. And I would completely agree with that.
Okay. Again, well done. Nice job.
Thank you.
Yes. I want to say that this was a well thought out, super articulate presentation, and you are a great presenter. So thank you so much again for presenting today for the Journal Club. And then I already threw the document in the chat. Next week, we have a presenter who will be talking about a solution to diagnosing episodic dizziness. Student Dr. Donald Keating is going to talk to us. So I hope you'll join us next Friday. Until then, have a good weekend, everyone. And thank you so much again, Student Dr. Bednar.
Yes, thank you so much for having me on.
All right, bye, everyone.